Thank you. Good morning to everybody. Actually, left main dissection causes are similar to all dissection happening also in other sites of coronary circulation. That means guiding catheter manipulation, contrast injection, guide wire manipulation, guide wire extension, balloon stent inflation, balloon rupture, particularly in calcified lesion at the ostium of both right coronary artery or left main. The use of intravascular imaging catheter sometimes can also produce dissection or any combination between these factors. And as you can see, the guide wire advancement as well as stenting and balloon angioplasty are the major causes of dissection, as have been reported recently by this study over 5 years on more than 10,000 procedures. The type of dissection, we know that there are several types from A to B, C, D, A, and F, accordingly to the characteristic of dissection extension. And the most frequently encountered are type B and type C, as have been reported in many other studies. And of course, sometimes intravascular imaging can help more in to characterize more detailed with more details about the dissection and the extension of dissection. Now, Esther Hardy's simplified classification for left main, specifically for left main, you can see that type 1 is limited only to ostial or shaft of left main or distal left main dissection extending to LAD or circumflex, and finally also to retrograde dissection extending to aorta. And most frequently is type 1, followed by type 2, and more rarely is the extension to the aorta. The extension to aorta can be different. That means can be localized only around the ostium of left main or the coronary sinus and the ascending aorta, but less than 40 millimeters in extension, or more up to the ascending aorta more than 40 millimeters. And this was defined by Dunning classification. Type 1, class 1, type 2, and class 3, as you can see, accordingly to the extension on the aorta, dissection on the aorta. And you can see from this very large cohort, you see that the extension to the aorta is very rare. That means it's 0.07 nearly percent of the daily what we are doing in daily practice, and accordingly also to our other cohort, still confirming that it is the involvement of aorta is rare, as you can see here. This other cohort showing that the extension or aortic involvement is in 0.21, and left main involvement in this cohort is 33% of the iatrogenic dissection of left main. Left main, and again in this other cohort, the incidence still rare. That means 0.09, and all among iatrogenic catheter-induced coronary dissection, can see that left main is involved in nearly half of patients, and right coronary artery in the other half. And if you see also, there's no relationship with the catheter used and the curve used, as well as the distribution of type of dissection and the kind of at each vessel, and the treatment or delivered is mostly stenting in all cases. There is no association between the access, access site around the access side and the incidence of iatrogenic dissection. In the transfemoral era, it was more frequently encountered in transradial approach, but nowadays there is no significant difference between transradial and transfemoral approach. And if we look about clinical management and outcome, can see that the medical therapy that means conservative is still used, but in small percentage of cases. The most used is bailout stenting, and it is good to know that clinical outcome is also good, that as measured by death during index procedure or death during coronary artery bypass grafting, and death in hospital, as you can see here. This is from Japanese cohort showing that there are some predictors like female gender, complex lesion, or proximal lesion. And now I'll just show you some cases, and in some situation it could be absolutely easy to manage the dissection, and also with very good outcome. This is a dissection caused by balloon inflation involving distal left main, LAD, and circumflex. You can see you have already your wire there, and just crossover stenting from left main to LAD will treat effectively this situation. As in this also case, the manipulation of guide wire to access LCX was causing dissection in left main. And again, since you have your guide wire inside, again, stenting will be very effective in treating this situation. Another case with dissection caused by guiding catheter, just the first injection in primary angioplasty for anterior STEMI, and you can see the dissection on left main because of deep intubation of the catheter injecting the contracts. And in this case, again, the first thing to do is to fix this dissection with wiring LCX and stenting left main, and then completing the primary PCI to LAD. But of course, in this situation, patient was coming with STEMI, and then as the dissection was occurring, the patient was having low pressure, and so the mechanical circulatory support was needed and was placed. Many other case reports on the efficacy of this kind of approach, that means stenting, and even conservative management with catheter-induced dissection. Finally, this case, so the left main, the distal left main disease, you can see here also right coronary artery diffusely diseased. This is what happened after wiring left circumflex and just checking with the guiding catheter. And you see that the guiding catheter is pushing on, it's not coaxial, and pushing on the wall of the left main. And can I have just 1 minute, please? More? Yeah, pushing against the wall of left main, and you can see here the dissection is extended to the aorta, less than 40 millimeters. So we proceed to stenting, and stenting with 4 ohm stent was not sufficient, because you can see even after the stenting is still having some port side, that means still having the passage of blood into the into the dissection. When we post-dilate with 5 O balloon, and this was fixed completely, as you can see here, in final angiographic result. And by take-home message that left main iatrogenic dissection is a coronary angiography during coronary angiography or intervention. I think that stenting in most cases can be effective and should be done as soon as possible. Only cases with extensive dissection, retrograde dissection to the aorta might need surgery, but in these cases, I think patient can be stabilized also if you can stent the dissection entry site with a stent. Thank you very much for your attention.